All right, so they gave me this walking microphone so I can stand behind the podium and not have to worry about it. So I know nothing about the future of neurocritical care. When I got this invitation, I said, well, that sounds nice, but what am I going to do? So first I want to tell you that I'm not going to talk about the future of neurocritical care. I'm going to talk about futures, because there are many different ones, but the divisions between them are arbitrary. So these are the usual disclosures, but my real disclosures are that I actually enlisted the aid of several past, present, and future officers of the NCS. So this is a joint effort here. I'll take the responsibility for things that don't sound right, but I had a lot of help, and also from my wife, who looked over my slides and made a lot of suggestions. So don't blame anybody else for anything that's wrong. Well, the future can be frightening. Those of you who might remember the old Twilight Zone know that a young William Shatner starred in an episode where there was a gremlin out on the wing of his airplane, and he kept trying to convince everybody that there was danger, and no one would listen to him, because whenever anybody else looked out there, they didn't see it. And at the end of the show, they carry him off in a straitjacket because he must be crazy. But then the engineers discover that this thing has been attacking the engine, so it really was true. So there could be frightful things in the future, but maybe not always. So I thought I ought to learn something about prediction, since I'm supposed to predict the future. I know nothing about predicting the future, but this is a very interesting book about it. And I learned some important things, but the one in yellow is the most important one, which was to break this seemingly intractable problem into tractable subproblems. And that's why I'm going to talk about the futures. But first, a disclaimer, you should never listen to my predictions. A fellow came to my office and said, what do you think about midazolam as a treatment for refractory status? And I said, well, I don't think that's such a good idea. The pharmacokinetics are all wrong. And I kept babbling. And he finally stopped me and said, well, I tried it in the last 2 refractory status patients and it worked. So I was smart enough to shut up and listen. All right. Secondly, I thought that tight glucose control was going to be an important advance in the management of neurocritical care patients, which hasn't quite turned out the way I thought it would. I was skeptical of the value of brain tissue oxygen management. Mary Kay Bader came and talked to us about it, and I thought, how can this little sample of the brain actually mean anything? But anyway, I've been converted on these things. Well, why should we care about our history? I'm going to use the history as a way to sort of jump forward into thinking about the future. So most of you have probably heard this quote, those who do not remember the past are condemned to repeat it. But what you may not know is that Santayana also said history is a pack of lies about events that never happened, told by people who weren't there. Well, for once I can tell you I was there. All right, so this was the outline of that talk that I gave back in 2003 in Phoenix, and we're still dealing with many of the same problems here. These are some of the early people that actually got the field started. You'll recognize some of them. Some are from the US, some are from other countries. That guy down in the lower left there, I don't know who that is, but actually I was a medical student anyway. So I thought the best guide to our future might be to say where it was we started and how we got to today. So for those of you who aren't as old as I am, and as far as I know, there's nobody here who's as old as I am, I want to tell you what neurocritical care was like 30 years ago when I started doing it full time. So subarachnoid hemorrhage was treated by putting the patient in bed with stool softeners for 2 weeks and hoping they survived. If you were still alive at the end of those 2 weeks, then you got an angiogram. And maybe your aneurysm was clipped, or maybe your carotid artery was closed off to decrease pressure on the aneurysm. Aneurysm coiling then was a radical idea. So I had the opportunity to work with Jacques Dion when he came to the University of Virginia in the early 90s to introduce this notion of coiling. You know, what a strange idea to stick something in that aneurysm via a catheter. We were in the middle of a phase 3 trial of TPA for acute ischemic stroke, and this actually wasn't published until 1995. The trial had been going on since the late 80s. But before that, stroke was thought of as a pretty easy admission. I mean, you did a history and physical, put the patient to bed, and hoped they survived, and then called rehab because they were the only ones that could actually accomplish anything. This was an EEG machine, for those of you who've never seen one. EEGs were recorded on paper during working hours, and I had to come in and hook the patient up myself and run the machine myself if I wanted an EEG on nights or weekends. You can imagine that if you were trying to do continuous EEG, you'd use up 3,000 sheets of paper a day, running it at half speed. So this is one of the reasons that EEG monitoring didn't become popular really until the Moberg device that we'll talk about another time. These were the treatments for generalized convulsive status epilepticus. You notice this paper wasn't published till 1998. The study was going on from the late 80s. In those days, there was not really such pressure to get your results out early. So the study had been finished about 3 years before, and it finally ground its way through the publication system. But what did we use? Well, we used lorazepam, still do that. You notice the other drugs here, phenobarb. Actually we have a now resurgence of the use of phenobarb, but for refractory status. But it was one of the first things that people tried back then. When we tried to think beyond these simple drugs, what could we do? People started looking at NMDA antagonists, and now 30 years later, we're still studying whether NMDA antagonists are in fact going to be useful in this management. Pentabarb was a very classic idea then. We used a lot of thiopental as well. Of course, thiopental is not available in the US anymore. But the idea that burst suppression was a target was cooked up by people who thought when you went into burst suppression, it meant you couldn't have a seizure. And they thought this because they thought it, right? And sometime in the late 80s, we showed that if you did those continuous recordings, which I didn't do because I thought that was the right thing to do, it's because I had hooked up the machine, but I got distracted and left it running instead of turning it off. We discovered that people were seizing all the time when their background was burst suppression. So just in addition to not listening to me, don't listen to anything else anybody told you. All right. So in 1990, we got the first results of CT scanning and head trauma from the Traumatic Coma Data Bank. And the Marshall scoring and everything that followed from that really wasn't available until 1990. So that was something that actually took us all by surprise, that you could start to predict prognosis based on the CT scan. Prolonged hyperventilation had been a common treatment for increased intracranial pressure and head injury. And this paper was often cited as the one that told you that it was a bad thing to do. So before this, people would do it for days on end, right? So this paper's title sounds like you probably shouldn't do it. But what did the data say? Well, this study was terminated prematurely because at 3 and 6 months in the outcome measurement, patients who had a motor score of 4 or 5 did worse if they'd been hyperventilated than if they hadn't been. But this was not a test of treatment for increased intracranial pressure in the setting of head trauma. It took in all severe head injury patients. So as a consequence, you might say, well, what if you only treated patients with increased intracranial pressure? And by the way, that treatment effect was gone at 12 months. But nevertheless, this led to a blanket prohibition on the use of hyperventilation in head trauma beyond the first hour or so, where you're trying to get other things stabilized, maybe get your hypertonics in, which back then was always mannitol, and maybe getting the patient to the operating room. Multimodal monitoring was a new idea back in 1990. Now, we had done microdialysis in animals as a research project for years, but this group in Sweden was the first to actually show that you could do this in humans. I think from a research standpoint, this has been extremely productive. As it makes its way into more clinical practice, we still have to deal with problems like the dwell time of the artificial CSF within the fiber. But multimodal monitoring started, at least back then. If you had somebody in refractory status, we blamed it on SSE, right? Well, what was that? That was some sort of encephalitis, presumably viral. We didn't know about things like autoimmune encephalitis yet. So a lot of patients were basically written off, say, well, they're not getting better from this viral treatment, or from this viral disease, and we have no efficient treatment for it. Although in the 1990s, we started to realize that if you kept some of these patients alive long enough for their seizures to stop, some of them would actually have a good outcome, which was an unknown idea back then. I will tell you that we don't know much more about the pathophysiology of status now than we did in 1990. This is a seminal paper, and I still show the figure because we have nothing better. Septic patients were encephalopathic because, well, they're very sick. That's why they're comatose. And that's what my resident told me when I was a medical student. And I have to say that that thought still seems to hang around in the world a lot. Sorry, I gotta get my prop out here. I meant to sneak up here and do it beforehand, but I didn't have a chance. All right, so now I need to sort out the history, and I thought, what sort of cultural icon will everybody understand? So, here we have history. All right, unfortunately there are two screens, so I can only point at one. All right, so I'm going to sort out the futures now. So there'll be a clinical future, a scientific future, a technological future, a political one, an economic one, and a philosophical one. So before we go on, I just want you to understand what my wife thinks about all this. All right, so clinical future. Our big problem is going to remain staffing of the ICUs, not just for the next year, but for the foreseeable future, because resources are limited and we're going to have to find some way to make better use of them. We're going to have to make better triage decisions. Now, for a few conditions, we're going to have large phase 3 trials to help us understand therapies. But many of our conditions are sufficiently rare that phase 3 trials will never get funded or may not even be possible. So we need to have some other way to make clinical decisions besides just using phase 3 trials. We can't use this sort of earlier evidence-based medicine approach where if there's no phase 3 trial, you can't do anything, right? That's not going to work. So big data, hopefully through large registries, will provide some of that data. And for those of you who are familiar with what's been done at Vanderbilt in the last few years, they actually randomize intensive care units to various therapies that are already acceptable, but nobody knows which one's better. And they've termed this the Learning Intensive Care Unit. This is a phase 3 trial that worked, but notice these are drugs that were already approved for the treatment of epilepsy. The ESET group has done a lot of good work, hopefully will continue to do so. In terms of the Vanderbilt studies, you might be interested in this one in particular. So they looked at patients with head trauma and randomized the ICUs that cared for those patients to having balanced crystalloid 1 month compared to saline the next month. And then over years collected enough data and came to the conclusion that in fact balanced crystalloids had a worse discharge disposition than giving saline. Well, we've been hearing for a year or two now how bad it is to give saline because of the hyperchloremia that gets produced. I think one of the explanations for this may be that the balanced solutions were in fact slightly hypotonic and contained glucose. So there's a lot to learn about these systems, but this is the sort of thing that would allow us to gain knowledge without having to wait for somebody to get a phase 3 randomized trial funded, because nobody's going to pay to do a study of, say, lactated ringers or plasmolite versus saline. But this kind of information we can hopefully derive in the future. Now, Michael's done a fantastic job with the journal. He's started these topical collections. Curing coma, of course, is an important one, but pay attention to cortical spreading depolarization, because that's, I think, going to be one of the major advances in our understanding and hopefully in our treatment of patients. Performance measures could be collected through big data, and I think that's something we'll all have to rely upon. Predictive analytics, I don't foresee a day when we're going to screen patients who are referred to us from the emergency department and say, well, this patient is not going to come to the unit because we predict their outcome is so bad. But we can use predictive measures to figure out who should get what treatment quickly and then to speed up our prognostication. we need to disseminate knowledge and skills that we have. So this study with Loke McDonald as the principal author looked over time at patients with subarachnoid hemorrhage who were admitted either to an urban teaching hospital, which is the lowest line, an urban non-teaching hospital, the grayish line, and rural hospitals, looking at the mortality rate over this several decade period. And yet, whereas you can see that the mortality rate is declining in the urban settings with the teaching hospitals slightly better, the rural hospitals are actually having an increasing mortality rate. Now, some of that could be better referral. So patients not being left in a facility that only deals with 2 or 3 ruptured aneurysm patients a year, sending them to the urban teaching hospital is sort of the Will Rogers effect. If you don't know, Will Rogers said that when the Okies left Oklahoma for California, they raised the mean IQ in both states. So here it may be that the sicker patients were being referred, but nevertheless, one of the things to keep in mind is that for some conditions, regionalizing care is really quite important. So this looks at the mortality rate in patients with subarachnoid hemorrhage compared to the number of cases done per year. As you can see, as with most things, the more you do, the better you are at it. So the future belongs to people who understand Bayes' theorem. And we can do a much better job of helping to predict outcome and eventually perhaps sorting patients according to the therapies that would be most beneficial if we also add in Bayesian prediction in addition to doing frequentist statistics on people. This is not one of my grandchildren, but it's about the right age. So the kids are starting early with this, and we need to catch up. Well, what are the boundaries of care? We start to assume that, well, this treatment worked in the first 6 hours, so we should only use it in the first 6 hours. I think the message is not the treatment being limited. The message is we need to understand where the limits are and then push the limits. So this group is looking, for example, at how far out can you push thrombolysis here, thrombectomy, sorry, and to what aspect score, right? So if you think that you shouldn't do it with an aspect score less than 5, well, maybe that's not correct. But we shouldn't just go out and do this for the hell of it when we get back to work. We need to study these things in order to make the future more promising. This is, I think, going to be something that will really improve outcome. Of course, it's just an experimental issue now, but if you start resuscitation in a cardiac arrest patient supine, but then if the patient doesn't respond immediately, you start raising the head of the bed, you actually result in a situation where you get better cerebral perfusion with your CPR. Because if you keep doing it down like this, you have so much impedance to venous return. In the animal models, there's very little flow actually going through the brain. And as you raise the thorax up here, you actually improve venous return. And in this study, you actually see much better survival. Now, who's the trigger for all this? Paul Pepe, who's been a part of our work for a long time. These sorts of innovative approaches need to be followed up, but I think this is one that will stand us in good stead in the future. We also need to work on better ways of weaning patients from a ventilator. I think our pulmonary critical care colleagues obviously have done a lot of work on how patients could be weaned, but this is a different group of patients, and we need to understand the difference in their physiology. There are always going to be some new problems to conquer. As I mentioned before, in 1990, we knew nothing about autoimmune encephalitis. When we met in Vancouver in 2017, nobody knew that there was going to be some little virus that was going to change the world so dramatically. I don't know what the next new thing is going to be. That's beyond my ability to predict. But nevertheless, you need to be aware of the possibility and be open to it. Do our treatments make a difference? All right, so this has been a bone of contention for many years. There have been a few studies here. This one is relatively recent, done by a group of people who didn't have a vested interest in whether neurocritical care worked or not. They just wanted to know. So they did a meta-analysis. Understand that meta-analysis is to analysis as metaphysics is to physics. It's not real science, okay? But it's a clue to where we should look. And you can see if you go all the way down to the bottom here that there is a statistically significant improvement in outcome when patients with our conditions are cared for in a dedicated neurocritical care setting compared to being cared for in a general intensive care unit. Other people had looked at this. This is some of Andreas Kramer's work in southern Alberta, showing that for some conditions, in particular subarachnoid hemorrhage and head injury, there was a statistically significant improvement if you're cared for in a dedicated neuro unit. On average, these diagnoses are all better off in a neuro unit. Standardization has been a big push. Everybody's got checklists. You have to do things according to the quote-unquote guidelines. At the same time, there's a push for individualized care, and the tension between these two has the possibility of making our lives miserable, but also sort of taking a guideline-based approach and then applying individualization of things like pharmacogenetics, hopefully has the opportunity to take advantage of both of these schools of thought and improve outcome. Well, what's our scientific future? At our meeting in 2006, Alan Roper gave a talk which could be summarized as, we should own the science. But what is the science of neurocritical care? Is there something that is special to us that is less commonly the province of other areas within medicine? Well, we could look at both preclinical and translational ways to go, but also clinical, for which the Curing Keynote campaign, I think, could be quite a model. One unanswerable question at this point is, how can we get people entering neurocritical care to devote time and energy to science when their chairs are telling them they've got to just make more RVUs? Or from the nursing standpoint, that you've got to have more staffed beds. You can't devote any of your time to being thoughtful. So we have to have laws, and some of you may remember the laws of the House of God, number 13, the delivery of good medical care is to do as much nothing as possible. And when I was a neurology resident, that was pretty much the mantra of my professors, who told me not to be so aggressive in these locked-in patients. You know, somebody came in on a Friday and I had them trached and pegged by Monday morning, or not pegged, we didn't do pegs back then, but a gastrostomy. And my professor criticized me roundly for doing this to the patient who I should have just allowed to die. It was a younger patient who actually did quite well over time. But at any rate, the idea here is that we have to have something that we're going to do that makes neurocritical care special. So these are what I think are the laws of neurocritical care. First, at the cellular level, most of the things we're dealing with share a few common mechanisms. So my first law is that you need to keep the intracellular free calcium concentration at an appropriate level. Of course, you can't measure it directly, so we have to take studies from the laboratory and translate them into our human patients to try and figure out how can we do that. So if you keep that concentration normal, you control the activation of enzymatic systems that are triggered by that increase in intracellular free calcium, so calpain and many others, that lead eventually to neuronal and to astrocytic injury and to death. Now, a lot of these systems, in fact, all of them, obviously are there to support normal brain function. So if you interfere with fluctuations in intracellular free calcium, you'll prevent memory from being formed. Maybe that's not such a bad thing for our patients, but I don't really care if a drug like MK801 is not useful as an ambulatory patient's treatment for epilepsy, because all I care about is keeping their nervous system as intact as possible until they can recover from their critical illness. So drugs that have been discarded in the past may in fact be quite useful for this. A second goal is to prevent or mitigate damage from oxygen-derived free radicals. All right, so now how do we do that? We've tried numerous pharmacologic approaches in the past. Things like Terilizad and PEG-SOD were the subjects of many trials back in the 1990s. We didn't pay enough attention to how do these things get into the brain. You know, there were a lot of times when drugs that looked promising in an experimental model where, for example, you loaded an animal with the drug before an experimental head injury, and when it was helpful in that setting, we immediately went into the clinic and said, you know, let's give these drugs after the head injury. Well, somehow the sequence of what goes on here has to be important. So Terilizad probably does work if you give it enough time to get into the brain, but now you're talking about days. So we need to find better ways to do this. Our third goal should be to modulate the activity of the immune system as it deals with damage to the central nervous system. Again, how you do this is going to be different in each of the conditions we deal with, but I think it's important to keep these goals in mind whenever we're evaluating new therapies. Well, there has been advance in science. When I was a resident, there was this thing called the reticular activating system, and somehow it acted like a pacemaker for the brain, and it was somewhere in the middle there and all that gray stuff. But people have actually honed down a lot more in recent years on where these particular structures are. You know, if you have a big lesion in the middle of the midbrain, you may be initially comatose, but the brain has some way of bypassing that lesion and the patient's able to regain consciousness. Whereas this structure in the pons here, right by the fourth ventricle, appears to be crucial, both in the Parvizi and Damasio study and more recently in the Fisher study. These are based in human studies doing fine detailed MRI to determine what lesions predict irreversible coma versus the possibility of awakening. So this sort of thing is a basic science of neurocritical care. There's now what has been being touted as an animal model of delirium. I don't want to get into what is delirium and why the definition of delirium is completely stupid, but I don't have an opinion on it. The idea here, though, is that there's an animal model of something. What the animals are doing is not picking at the bed sheets and hallucinating. They're probably encephalopathic, but this is the group, as you can see, Wes Ely is part of this, that is actually trying to come up with a more basic science of disturbed mental function in the setting of acute illness. And this, I think, will lead us, hopefully, to better understanding and to better therapies. Of course, our Curing Coma campaign is going to be quite important in this regard. How about subarachnoid hemorrhage? It takes up a big part of everyone's efforts within the intensive care unit setting. So what is the pathophysiology of the underlying condition? So we've had many potential thoughts about what could go on here. So these two illustrations cover many of the possibilities here. And of course, if you're standing at the bedside and thinking, how many of these are subjects for intervention? Obviously, it would take many lifetimes to study all of them. So we need to have better preclinical studies that can then allow us to apply these things. You notice in the middle here, there's a lot of emphasis on nitric oxide. Over to the right here, we've got problems with the glymphatics. Over on the left, we've got a number of things like endothelin expression. We've known about these things individually, but we've never had good ways to intervene in them. And I think this, for the future, is part of the roadmap. There's also going to be a lot of emphasis on microthrombosis. I think is one of the more promising avenues of trying to deal with what we have tended to call vasospasm or DCI or DNI or whatever you want to call it. It's clear that what you see on the angiogram is not the only cause of what causes long-term disability for the patients. So we really need to understand this at a much deeper level and to be able to move ahead in trying to interfere with some of the pathogenetic mechanisms that go on here. Something that's been percolating for a long time and that we as a society have had some contact with is the notion of spreading depolarization, delayed whatever you want to call it, getting back to the spreading depression of Liao from the 1940s. This notion that it's a cause of delayed neurologic dysfunction in subarachnoid hemorrhage, I think is quite important. Can we do anything about it? So it's clear that if you have a lot of these depolarizing events that's associated with infarction in patients with subarachnoid hemorrhage. Now, those of you who have migraine, which is probably about a third of the people in this room, because neurologists tend to have migraine, and of course they have classic migraine, you're used to spreading depolarization as the cause of your migraine aura. But of course, at the end of your migraine, you just get a headache from vasodilation. There's something about these acute illnesses that when spreading depolarization occurs, results in ischemia rather than vasodilation. If I knew what the answer was, I'd have a Nobel Prize, and clearly I don't. So we still need to understand what's going on here. But Jens Dreyer, who has done a lot of the work in this area, I think is going to be one of the people that will lead us to understand what goes on here. And in fact, the number of depolarizations that occurs begs the question of how can we stop them from occurring. So if you had a couple, it didn't look to be a problem. Well, it may be that one of our more interesting drugs in neurocritical care, in fact, will be a useful way to interfere with these depolarizations. And then we, of course, will need to move on to human studies to see whether that's true. There haven't been a lot of other good candidates for interruption of spreading depolarization or for preventing ischemia in that setting, but ketamine, I think, gives us one of the first attempts to look at this. Of course, throughout critical care, there's the whole notion of what should the target hemoglobin be, right? I was raised with the notion that it should be 10 unless it should be 11. And how did that come up? Well, if you looked at the likelihood of increasing viscosity as a result of raising the hemoglobin, that was counteracted by the oxygen carrying capacity as a consequence of raising the hemoglobin. And the point at which you probably got the best theoretical oxygen delivery at the microvascular level was thought to be 10 or 11, depending on how you drew those lines. Then a lot of studies, of course, came out that said, well, your patients do just as well with a hemoglobin of 7 as they do with a hemoglobin of 10. So what's the answer to this question? Well, if you look at both studies, they've almost always excluded our patients because nobody was willing to take a chance that maybe the mechanisms that we deal with could be different than the patient who's having a hemorrhage or who is having a heart attack or who's got ARDS. So people are now starting to look at this as looking for the optimal threshold, but I don't think our patients have an optimal threshold. And I think one of the big advances in this area will be in the BOOST 3 trial to see what the use of transfusion to improve brain tissue oxygen contributes. So I suspect 10 years from now, we'll have some way, perhaps non-invasively, to say that this patient's oxygen delivery is diminished and we should have more hemoglobin on board, among with other things to do. So looking for one single number, the way that the rest of critical care seems to be approaching transfusion, is probably the wrong answer to people with increased intracranial pressure or cerebral ischemia. Well, there are new kinds of science, and this one, this sort of look for interconnections here. This is actually looking at aneurysm research by the senior author, and how are these people's papers and their research connected to each other. So one of the ways to get into a new field will be looking at this kind of bibliographic or bibliometric analysis to figure out who's been active in the field and perhaps whose papers you should first pay attention to or with whom should you collaborate. All right, what's our technological future? Well, in the short term, our technological future is dependent on learning about how to do functional MRI and machine learning as applied to our patients. And my caveat here is that people who talk about machine learning know that it's written in Python, a very powerful computer language for doing machine learning, but people who talk about artificial intelligence are only writing in PowerPoint, right? Because what they're doing is nowhere near the depth of the machine learning analyses. I, however, benefit from natural stupidity rather than either of these. So increasingly, though, our technological focus is going to be on non-invasive monitoring techniques. So this paper, which I'll talk a little bit more about this afternoon, looks at how can we apply physiologic data in the classification of level of consciousness. We can also use this hopefully as a way of predicting recovery of consciousness. So one is rating the patient currently, the next is can you predict who's going to regain consciousness. Functional neuroimaging, of course, people are aware of early studies from people like Adrian Owen that it showed that some patients who appear to be locked, well, I don't appear to be locked in, they appear to be either comatose or in a vegetative state, actually are awake and can respond to external stimuli by changing blood flow in their brain. So the index patient was someone who would activate areas in the motor cortex when asked to think about playing tennis, and activate other areas when asked to think about walking around the house. This was quite reproducible, and they were the same areas that patients who had normal mobility activated. So this patient, and now there have been many others, clearly was awake and understanding stimuli, and obviously likely understanding and feeling a lot of other stimuli, even though they had suppressed motor output and were unable to make the kinds of responses that we use to judge consciousness. So, David, you're going to have to figure this out. Some of these supposedly dead people probably aren't dead either. All right, so this is just an example of those areas. Can we use these machine learning methods to improve things that we do every day? So this from Eric Rosenthal's group at Mass General looked at how can we predict who's going to be able to wean from anesthetics and refractory status, but not just looking at the raw EEG, analyzing the EEG to figure out whether there are predictors that can determine whether the patient's ready to be weaned or not. I look at a lot of EEGs, and I couldn't look at this and know without these sorts of analyses whether that EEG means the patient might be ready to wean or not. This has been one of the big problems in refractory status. I don't know whether I've succeeded until I fail. One of the non-invasive techniques looks at near-infrared spectroscopy. So now this is looking at another of my interests, septic encephalopathy, and can you judge what the optimal blood pressure ought to be for a patient with septic encephalopathy? And by looking at measures of autoregulation, varying the blood pressure and seeing what this non-invasive measure of cerebral perfusion is, one could come to essentially a sweet spot for the development of a blood pressure algorithm. This happens to agree with the Surviving Sepsis campaign that the median, or the pressure that you're looking for in terms of mean arterial pressure should be around 65, but it could be different in each patient. So this is a technique that I think is of some value. Patients with focal brain injuries, it's probably not as useful as it is in people with global brain dysfunction. We've tried this in subarachnoid hemorrhage, and I think the subarachnoid blood interferes with the signal to the point where it's not useful there, at least not in its current manifestation. But as with all technologies, you need to be careful in its application. So you can get a pretty decent brain oxygen signal out of a squash. Now, you might be characterizing your patients as having a squash, but these are real squash. As you'll notice, the authors have carefully maintained their anonymity. Well, cerebral autoregulation monitoring, I think, is something that has been done in a number of centers as a research technique. Is it ready for prime time yet? I think it's getting there. I think it's something we'll do a lot more of in the future. Some of the technology to do it is still evolving, so if you wanted to use a constant TCD monitoring as a way of helping to come up with things like the PRX, you need a device that will do reliable continuous TCD monitoring. Some of them seem to be evolving. All right, our educational future. So here I accepted PowerPoint's suggestion of how to make slides acceptable to Generation Z. So I can't just list everything in a line, I have to put it in boxes with a lot of colors. But I think we do have to accept that there are generational differences in learning styles, including the visual presentation of information like this. We need to have more shared educational materials and experiences across professions. We shouldn't be in silos of profession X learns this way and profession Y only learns these other parts. I ought to know what a social worker needs to find out, something that I was never trained to do. The future, though, for education is probably in proficiency-based as opposed to time-based training models. That's going to be very difficult to apply to residencies and fellowships where a lot of what's done is simply using people as cheap labor, right? I used to think, well, you can't possibly learn enough if you only did 2.5 years instead of 3 years, but people learn at different rates. And achieving proficiency is something that should probably be the marker of when your quote-unquote training is over, after which you just admit that they're cheap labor and keep them for the rest of the time. So one of the other things that comes up here is that I don't know that the future at all looks like the way the physicians were trained in my day. So I did a medicine residency and a neurology residency. Is that the right thing for someone like me. Can you do a neurology residency and 2 years of critical care? Can you do a neurosurgery residency with a 1-year infolded critical care fellowship? Can you do medicine or anesthesia and then do a year of general critical care and then do a year of neurocritical care? These have nothing to do with meeting milestones, which, by the way the milestones are done now, I don't think are particularly useful, but we could in fact have a proficiency-based system for education that was not solely time-dependent. Within our fellowships, like I mentioned, those milestones are easy to draw, but if you've ever been the person responsible for determining whether somebody met them, they're pretty amorphous. You know, when I read through, for example, I used to go over the neurosurgical critical care milestones with the neurosurgery residents. Well, if I'm not watching them every day, then I'm taking self-report or the reports of other people. Perhaps a simulation-based system would be a more appropriate one. I'm not quite sure how to do that, but I know that when I sign these pieces of paper or check off a box on a computer screen, I don't really know what their level of competence is unless I've been with them. Work hour restrictions, I won't get started on how bad they are, but the main thing that you have to remember is that if you're going to restrict work hours further, you need to prolong the training because you're not getting enough patient exposure. And I think in the future we're going to have to figure that out. Specifically for neurocritical care, participation in the match should be mandatory. You know, it shouldn't be the issue of being able to offer positions outside the match. And those of us who deal with the current fellowship environment know that there's a contest between the UCNS and the ACGME on what the criteria for fellowship training ought to be, and in particular, who's going to collect money for it. The whole J-1 visa thing has been a fiasco, I think, really developed just to punish us. All right, FOAM, free open access medical education. It's sort of like what's at the top of your coffee cup. You know, how dense is that foam? It's not very dense, right? What you have to keep in mind is that I could start putting out continuing education on cardiac surgery. What do I know about cardiac surgery? It causes complications that I have to take care of. That's about all I know about it. But there'd be nothing to stop me from publishing long screeds online about this, you know, you shouldn't have replaced it with that valve, it should be this valve. So there's no peer review in foam. There are some wonderful things that are written, but if you don't know the material already, you don't know how to evaluate it. So I'd like to see some improvement in the way that's done. But basically, if your peer review is done on Twitter, you're going to end up just the way the politicians are. Work-life balance. One of my first things to counsel my fellows about when they're talking about their potential future jobs is don't start the conversation by saying you're interested in work-life balance, right? It may in fact be what you're interested in, but you're going to turn off people who are certainly anywhere near my generation, but in particular, your work is part of your life. And you need to accept that your work is part of your life. There's always going to be a conflict between your career and the rest of your life. And part of being in training is learning to manage that conflict. When I was a resident, we used to have these things called shock rounds, where a senior attending would come and select the paper charts for different patients and ask another intern to present the patient. And everybody lived in fear of this. But one of the senior people who did this, who was, in my mind, quite malignant about it when he was in that room grilling you, afterwards said, one of the things you're supposed to learn in training is how to protect yourself and how to care for yourself. But nobody ever said that out loud. So yes, part of training is learning how to work that work-life balance. But if your only goal is to have 2 weeks on and 2 weeks to go skiing, then maybe this isn't the profession for you. Well, what's our political future? People like to talk about the big tent. So are we the big tent for everybody who wants to be involved in neurocritical care? Early on, we had a separate group of pediatricians who wanted to do initially just, well, they got together to do neurocritical care research in pediatrics. A few years ago, they said, you know, In addition to what we do alone, we would like to be the pediatric section of the NCS, which I think is a fantastic move for both them and for us. Now they're all us. 67 members, that's good. There is a separate pediatric neurocritical care research group that has 60 institutions that feed into it. And then there are other ones that are pediatric emergency medicine groups. There are a lot of research groups that are related to it. But although they have their things that are specific to their patient group and to their research interests, we're all part of the same team in this regard. The next thing is, well, how do neurosurgeons who want to do critical care get to be part of the team? Some of you may know that although when the ABPN certification process was envisioned and people started writing questions for it, the group that writes the questions includes 2 neurosurgeons. Now, this group had to examine themselves. We had to actually answer written questions to certify ourselves as the initial group. And we have 2 very active, very good neurosurgeon neurointensivists who are part of that group. But the American Board of Neurological Surgery would have to submit the names of people who want to take the ABPN exam after appropriate training, and they've decided they're not going to do that. Instead, they have issued their own system for the recognition of focused practice that is going to be what a neurosurgeon who wants to be a neurointensivist is supposed to pursue. For the next couple years, the neurosurgeons who are currently on the examination committee will still be there, but if they rotate off, there will be no ABPN certified neurosurgeons to replace them. And that's going to, in my mind, deprive us of an important source of questions and also markedly decrease the credibility of the ABPN exam because we won't have that contingent of people. Now, some of us had worked with the ABNS on the accreditation of programs for people who want to do this or the recognition of focused practice. And one of the things that they stressed was, can you take care of your patient? Right? So your sick post-operative patient, other things that fall under the heading of neurosurgery, which generally we all deal with. But what it didn't include was, how do you run an ICU? How do you do infection control? How do you do the things that we all have to do day to day that are separate from the care of the individual patient? We've tried to convince them that that's important, but from a more strategic standpoint, I think this has been a bad move in its notion of a general idea of neurocritical care, and hopefully we can have them rejoin the fold. We have many other groups that are with us, of course. You're all here in the room today. We need to be the big tent. We are not a single profession. We're not a single specialty. We need to include everybody who's interested in the care of the patients that we have put together as being neurocritical care patients. And then there are administrators. Right? So our administrative colleagues, as opposed to, say, the American Academy of Neurology, have not really been in a group that we have tried to include, and maybe that's been our fault. But the more they know about what we do and what we need, I think the better off we'll all be. Again, our neurosurgeons are natural allies. I really covered that already. What's our economic future? Well, we're going to have to do more with fewer resources. I think that's pretty clear to everyone. You may be familiar with the American Board of Internal Medicine's Choosing Wisely campaign. So in different areas of internal medicine, they'll have 10 things like, you shouldn't order this particular test in this circumstance. Now, these are all high volume things. It's not looking at low volume issues, but perhaps we need choosing wisely in neurocritical care. How often do you need to repeat a CT scan? How long should you do continuous EEG monitoring when you're not finding something actionable on it? These are the sorts of things that we could, I think, back up with reasonable literature now, and are also areas that could be good avenues for research. Professional salaries, particularly I think for physicians, are going to be increasingly at risk as hospitals try to cut expenses, and in particular, if the future actually holds a bundled payment for, say, a patient who's admitted with a subarachnoid hemorrhage, that will leave us in competition with the other physicians who are caring for that patient. how is this going to be allocated in some sort of equitable fashion? We'll also see that the attempts of hospitals to cut costs are going to further reduce surge capacity, and we've all seen how much we needed surge capacity in the last few years and the consequences of not having it. Well, here's one of my favorite economic problems. The green bar are the number of administrators added to the population per year compared to the number of physicians. So if you want to know where the expenses are going up, it's not in the yellow part. How large should we be? So Woody Allen said that a relationship, I think, is like a shark, you know. It has to constantly move forward or it dies. And I think that's the driving force in a lot of corporations in terms of we have to expand, we have to gobble up our competition, we have to be bigger. Well, I don't think we have to be bigger. I think we have to make sure we have the right people at the table. And I think in many of our areas, except for bedside nursing, the right people are in this room already, right? Or they're online listening to us. So we ought to get everybody who should be a member, but we don't want to grow simply for the sake of growth. What to do about the rank and file bedside ICU nursing involvement here, I think, is something that remains unresolved, but one of the options is a greater degree of collaboration with the nursing organizations rather than expecting that they're going to all become members here. They're welcome here, many of you are in the room, but I think that it's unrealistic to expect that we're going to get people who have limited funds for continuing education or for conference attendance to give up what they're already doing and come to us instead. I think we need to work more with their organizations. This is a personal view. Well, have things ever changed in neurocritical care? This is, you saw a little bit earlier here, this was the Phoenix 2003 meeting. A number of these people are still here, but very few of them look like they did back then. And if you think we haven't made any advances in DEI here, this is last year's group. And I think you'll agree that it looks a little bit different. I'm actually hiding in the back there, but a lot of these people, I think, are there as a result of our understanding that everybody should be part of this group, and we need to have ways to see that they are included in the leadership. So how do we encourage diversity and still maintain excellence? I don't have some magic answer to this question. We also need to think about equity for our patients. Are they getting the care that they deserve, regardless of the background from which they come? And whether we're adequately inclusive or not, are we perceived as being inclusive? And I think that's important for us. What's our philosophical future? Well, a lot of the things we deal with could be prevented. Right? You go around the unit. I'm struck now often that I am the oldest person on the service, including the patients. Right? So people who are having strokes or having myocardial infarctions with neurologic complications and many of the other things we deal with, in particularly trauma, these are things that were preventable or at least could be delayed until the patients were much later. Do we have some role in trying to prevent these conditions? Well, not probably at the moment we're sitting at the bedside, although it has been noticed that we'll often discharge people who need to be on more antihypertensive treatment, and we haven't started that pathway. But all these things that we already know about that can improve outcome, we need to get the word out that you wouldn't need us if you were, in fact, taking care of yourself. What's our role in the developing world? How do we deal with the great variety in the availability of services, and what can we do to improve that situation? So these are things in the future I would like to see. So stress on prevention, I think we need to do because it's the right thing to do, and also because it will pay a long-term economic benefit and make our staffing and bed shortage problems a lot better. We do need to focus on better non-invasive techniques. Some of these I mentioned a little bit about. There are a lot that are in development. It would be great to say that we have a really good non-invasive ICP monitor. We have a really good non-invasive way of measuring focal cerebral blood flow without doing fMRI every day. We need to know about machine learning. Now, many of us won't actually write the programs that do it, but we need to understand its value and its limitations so that we can take the results of the research by the people that do understand it in detail, know when to apply it and how we can do that better. We probably ought to have some sort of prognostic scores that people have tried in the past with things like Apache, but machine learning gives us the opportunity to not only make a prediction on the first day, but to continuously update these predictions as more data become available. I think not that we would say on admission that, well, we're not going to admit this patient because their chance of recovery is too low. That I suppose could happen at some point in the future. But when we think about how frequently do we need to monitor particular things, how frequently should we be doing some interventions, we might be able to tie that to scores that are being generated this way as a way to apply resources more appropriately. We'll learn how to individualize our standardized care. Everybody should be enrolled in some sort of registry so that we're always collecting data about everyone. I personally think that all intensivists need better cross-training. And what the best way to do that is, I don't know. People are exploring different models for that. Maybe there should be a critical care residency that either precedes or follows a specialty residency. Maybe a combined fellowship system is better. There are pros and cons. You're going to gain some things and lose others if you are stuck in a time-based system. If you're in a proficiency-based system, that's hopefully a little better. One other option is that you finish a defined period of training and then you have some period of time as a junior faculty member or a junior associate where you're gaining more responsibility, but you are still viewed in some sense as a trainee. Cardiac surgery has been done like that for a long time, where people who have finished a cardiac surgery fellowship are declared finished when the supervising surgeon says that they're finished. So we need better research methodologies. There are going to be a lot of questions that we're never going to have a phase 3 trial for, and we shouldn't just say, well, we can't answer them. I don't know what those methodologies are. That's for you all to figure out. We're going to have better ways of assessing the literature. I personally don't see the grade system as providing guidance to people to the extent that it needs to be done. I don't know what the right mechanism there is, but I'm not encouraged by the growth of methodology outstripping the value of what we're publishing. We clearly need more research funding at all levels, and of course, you should run right out and donate to the foundation. We need better ways for ICU practitioners to be involved in more early research questions, both to help shape them and to understand how good the data are that are being derived from these studies and whether they're actually ready for clinical trials. I'd like to see all patients having advanced directives and a designated surrogate, so we're not in the situation of trying to figure out who's going to help make decisions for this person who is unable to do so for themselves. And a few things I'd like to see. We will cure coma, right? Now, when this concept was first imagined, I'm like, coma's not one thing, how are we going to cure it? But I think what the Curing Coma initiative now is showing us that yes, there are some common things we can apply, in particular common methodologies, to individual etiologies of coma. But as an umbrella for us to organize around, I think it's been quite successful, and it needs to be something that we all support. I never want to hear the term work-life balance again, because we will have solved the problem and nobody will be worried about it. And if you believe that, I have a bridge to sell you. But I really do think we need to move beyond the notion of this being some sort of adversarial relationship. Everybody should graduate from professional school without any debt. You shouldn't have to make decisions about your career because you need to do 10,000 endoscopies in order to pay your debts back. Real life shouldn't be postponed until formal training is completed. If you look at the people you went to high school and college with, you know that they were much further along in their lives at a point when you were just finishing your training. We should have everyone as a member of the NCS who should be a member and they should have a satisfying role in the organization. And we should get so good at prevention that we can all go fishing. And I'm 1 second over, so thank you very much.